Hey, my hustlers, so your exam is very near, just some days more. So, not always a hero is going to come and save you. Sometimes you have to be your own hero and save yourself. So, in this last time, just don't think of giving up and keep your motivation and confidence high. Keep belief on your done things. Whatever you have read for this, not only this last 1 year, but for last 5.5 years or 7 or 6 year, whatever is the number of years you have been in this medical education, everything is going to come to your help when you are on your computer screen in front of your screen in the exam. So don't worry, many give up when the victory is just a next step. So just hustle, keep your hustle on, because it is the only controllable pillar for your success, and refuse to be average. So this much of hard work you are not doing to get a average marks or average rank. Whatever your aim should be high to get a good rank and get your deserving seat. So we'll start with a very important session in this video, which will be dealing with some of the important questions which have a high probability of being asked in your examination, and some concepts which might help you in solving some more future probable questions. So if you see, can you make a diagnosis on this audiogram shown in front of you? So already I have made a video on audiograms. If you want to see, you can have a view from the course, but the first thing you have to see in an audiogram is whether it is a conductive hearing loss or a sensory neural hearing loss. Then you can fetch a diagnosis. So if you see your options, it is otosclerosis, Meniere's disease, noise induced hearing loss, and ototoxicity. So among that, first you decide whether it is a conductive hearing loss. Yes, it is a conductive hearing loss, as here you can see a air-bone gap. So what is air-bone gap? Basically, air-bone gap is difference between the air conduction and the bone conduction greater than 25 decibel. So, and you have no time to calculate, just see that there is a wide gap between the air conduction curve and the bone conduction curve. So it makes your diagnosis of conductive hearing loss in an easy way. For more descriptive, you can watch that video. So it is a conductive hearing loss, and among these options, what other things can fit into the diagnosis? Other thing you can see is in the bone conduction, you can see a dip at the 2000 kilohertz. So it is a dip in bone conduction at 2000 hertz, typical of Carhart notch seen in otosclerosis. So like that, you have to fetch your diagnosis by some key points. Dip at 2000, it's Carhart notch, and dip at 4000 K, you will write me in the comment. Dip at 4000 hertz, the diagnosis will be, then it will change to noise induced hearing loss. So moving to the other question, which asks you identify the name of the line shown in the photograph. So it is Ogren's line, which is an imaginary line, as you can see, extending from the medial canthus of the eye to the angle of mandible, and the significance is it is used for classification of maxillary carcinoma. So any growth, any maxillary CA which is situated above this plane has a poorer prognosis, while below has relatively better. So suprastructural or above this line is a poor prognosis of maxillary CA. Now this is something very conceptual the examiner is asking. They have asked you which of the following is the center for the stapedial reflex. So basically they are showing you a stapedial reflex, and if you see the normal pathway of stapedial reflex, and via this diagram also, if you don't remember in your exam, they have given you the flow chart. So basically, when you stimulate a ear with 70 to 100 decibel above the threshold of that ear, for protection, the ear has a reflex called stapedial reflex, where the stapedius tendon contracts and holds the ossicle. So basically ossicular fixation occurs. So how it occurs? The efferent you can see is via the eighth cranial nerve. So ipsilateral means the ear where you are giving the sound, cochlea will get stimulated. Then via eighth nerve it will travel to ventral cochlear nucleus, and then on the ipsilateral side it will go to the facial motor nucleus, that is seventh nerve nucleus, and here it will then go to the nerve of stapedius, and the stapedius muscle or tendon will contract. But on the contralateral side the pathway will be from cochlea to eighth nerve to ventral cochlear nucleus, then to superior olivary complex, and then to the other side of ventral cochlear nucleus, and then to the facial nerve and nerve to stapedius. So this is the normal pathway. So summarizing it up, the efferent is by the eighth nerve, the center is superior olivary complex, and the efferent is your seventh cranial nerve, because this seventh cranial motor nerve is causing the stapedius muscle to contract. So if you see, the center of this stapedial reflex is the superior olivary complex. So they have already asked, they might repeat, so just remember the pathway and the answer to it. Now again they are asking you, can you interpret the diagnosis by seeing this audiogram? So again it's a means more straightaway question. So here you can already see a earbone gap, so it is a conductive hearing loss. Now the key is whether of right ear or left ear. For that you should know and recognize the symbols. What is the symbol used for masking? So all of them have been defined in the audiogram, do watch that. And here it is conductive hearing loss of the right ear, because X denotes unmasked left ear conduction, and this O denotes unmasked right ear conduction. So average if you get the average of ear conduction in the left ear for 500, 1000, 2000, it is coming to be 10 decibel, while in the right ear it is around 70 decibel, indicating a 70 decibel conductive hearing loss in which ear? In right ear, because right ear has a more hearing loss. So anything above 25 decibel is described as hearing loss, whether it is in bone conduction or in ear conduction. Now tell me what testing is being done. So what is the name of the procedure shown in this figure? So this is basically the testing of vestibulo-ocular reflex by injecting the cold water. Now here some concepts are needed to get through the future questions also. So this is basically the caloric reflex test, also known as vestibular caloric stimulation test. So it is testing the vestibular ocular reflex that involves irrigating the ear with the cold or warm water. Sometimes in case of perforation, air is given, so warm air and cold air. So basically described by Robert Barani, who later won the Nobel Prize also. What we do is, you remember a mnemonic cows from your third professional. So C for cold water, opposite eye, W for means opposite side, and W for warm water, same side. Now what is the concept? If the warm water, that is warm, that is 44 degrees Celsius, and cold is 30 degrees Celsius or below. So if warm water is pushed, then what happens on the same side? The endolymph in the ipsilateral horizontal canal rises, causing an increased rate of firing in the same side of vestibular nerve. So this what it will cause is, it mimics the head turning to the ipsilateral side. Now what will happen is, both the eyes will turn towards the contralateral ear. So this is just, if you see, you move your head to one side, your eyes will move to the contralateral side. So both the eyes will turn to the contralateral ear. So if you are irrigating in right ear, the warm water in right ear, eyes will move towards opposite side. But what will happen is, the nystagmus, horizontal nystagmus, will be to the ipsilateral ear. So this makes warm water with the mnemonic, if you see, this was the mnemonic COWS. So warm water was same ear. So that means nystagmus will be same towards the same ear. So you understand the means your this eyes will be moving to the opposite side, but the nystagmus, which is decided by the quick component of the eye movement, so quick component will be towards the ipsilateral, that is the same ear. And when you irrigate with cold, opposite happens, the endolymph falls within the semicircular canal, decreasing the rate of firing, and the eye moves towards the ipsilateral ear, and the nystagmus will be towards opposite ear. So just remember this for the nystagmus cows, and you will get the answer if they ask you a advanced question. Now it is a simple, relatively simple, identify the clinical test shown in the figure. So basically they are showing you a Rennie's test and everything you know about Rennie's. So it will be positive in case of normal person or persons with sensorineural hearing loss, and negative when in conductive deafness, that is bone conduction greater than air conduction. So can you identify the paranasal sinus being tested by this technique? Yes, it is testing for ethmoid sinus. So basically, ethmoid sinus tenderness, and most specifically anterior ethmoid sinus tenderness, is being tested here by gentle pressure applied on the medial wall of the orbit just behind the root of the nose. So basically done when in case of acute ethmoiditis, to see whether they are inflamed or not, whether infection is present or not. Now tell me the radiological view which is shown here and what is the significance. So it has already been asked in your examination. This is the Caldwell Lake views. So the answer here is D and not Waters. So Caldwell's view, how you will identify it, is the occipitofrontal view, while Waters' view is occipitomental view. So it will be, I'll show you gradually what is the Waters' view, but just remember here the Caldwell's view looks like this, and it is best done for which sinus? For frontal sinus. So they have asked already key Waters' view is best for. So Waters' view is best for maxillary sinus, while Caldwell view is best for frontal sinus. So here you can see your frontal sinus very clearly. Okay, so this is Caldwell view or nose forehead position, and the Waters view is nose chin position. This is a simple instrument used in OPD by the otorhinolaryngologist called otoscope. So just a battery operated illumination thing which magnifies the tympanic membrane. You can see the tympanic membrane, its mobility. Also by attaching the Siegel's speculum you can do the fistula test to test. Now this is a magical instrument which is widely being used by otorhinolaryngologists. And can you name me and its indication? So this is the nasal Hopkins endoscope. So different types of endoscopes are there: 30-degree, 90-degree, 45-degree, 0-degree. For nasal mostly 0-degree is used, and nasals and the degrees, the angled also you can use. For larynx, viewing the larynx, 70-degree is used most commonly. So this is based upon the optical optical viewing. So the optics, a lens, cylindrical lens is present through which we can view the inside of the nasal cavity, inside of the larynx. So lot of things are done with this as a part. The functional endoscopic sinus surgery is done by this instrument. So for diagnosing any nose and paranasal diseases, diagnostic nasal endoscopy is done. In case of epistaxis, we do the endoscopic ligation of sphenopalatine artery. So lot of things can be done. You can take biopsy from suspicious lesion from the larynx and from the nose, which was very difficult previously. Now this is the ancient thing which is now still being used. So focal length of mirror in the instrument shown in this figure. So it is 25 centimeter. That makes it to 250 millimeters. So they have given it in millimeters. So it is 250 millimeters. The diameter of whole mirror is 89 millimeter, that is 3.5 inch, and central hole is just 19 millimeter. Now can you name me this instrument? Identify the instrument shown in the figure. So yes, it is lux forceps, used for variety of indications like to remove mucosa, to take some biopsy, to take the polyp which usually used to happen before, called polypectomy, to take different biopsy and the in different operations like SMR to remove the cartilage and others. So that was the lux forceps. Now this is very useful thing, that is Montgomery T tube. So here you can see a T-shaped artificial airway. See, it is a method of protecting the airway. So an artificial airway made of soft silicone tube like a T. So this T part allows the to support the upper airway, as well as the lower airway acts like a tracheostomy tube. So you can use it in the diseased upper way and support the airway after any airway surgery. This is another very important instrument used to keep the mouth open for intraoral surgeries, tongue surgeries, and usually it is applied to one side and just you can open the mouth and do your surgery. So what is the name of this instrument? It is Doyen's mouth gag. So in ENT instruments, procedures, radiology, so these things are very important and have a high probability of being asked. So you must know them and have a little concept about them. So what is the procedure being done here? So we were discussing about the audiometry. So this is just a pure tone audiometry being done. So this is how it is being done. Now tell me the name of this instrument. So whether it is a Vienna nasal speculum or a Killian's. So basically you should know how both looks like. So this is stout and short. So this is Vienna. They have also asked Killian's. So you can just see Google the Killian's. It is more elongated. So Killian's have a more elongated prong. Like this is small. Killian's will have a more elongated, more lengthier thing. So Killian's nasal speculum and Vienna. So this one was Vienna. Okay. Now this comes the Waters view that we were talking about, that is the occipitomental view or nose chin position, and with the open mouth we can also see sphenoid sinus. What best done for maxillary sinus, and we can see others sinus also. This is the Siegel's pneumatic speculum we were talking about, essential for the examination of tympanic membrane, gives us a magnified view of tympanic membrane and helps us to test its mobility, to see fistula test, to give some medications also sometimes. This is an indirect laryngoscopy. No, this is the posterior rhinoscopy. You see, you might mistake it like indirect laryngoscopy, but if you see carefully the image, the mirror is directed towards upward, that is towards the choana. So this is not an indirect laryngoscopy. Other thing is, in indirect laryngoscopy you hold the tongue rather than this depressing. So it is a peculiar or typical picture of posterior rhinoscopy being done. So what you all will see, you can see the posterior end of the inferior turbinate, discharge if there is any in the choana, any mass in the choana, atresia or choanal polyp. You can all see the choana examination, that is the examination of the posterior part of the nasal cavity with this posterior rhinoscopy test. Now in this diagram they want to ask the direction of nasolacrimal duct. So basically it's a easy one. What you need to remember is, many times you confuse, so just remember this diagram. So by this diagram what I mean is, the direction of nasolacrimal duct is downward, backward and laterally. So if you assume this as your nasal septum, this is your eye, this is your medial canthus, so it is going downward, backward and laterally means away from the mouth. Okay, so downward, backward and laterally, this is the midline, then it is going downward, backward and laterally. So this is the normal direction of nasolacrimal duct. I hope you won't forget. Okay, so which test is being done here? So this is just functional examination of nose called cold spatula test. Here a tongue depressor is held just below the anterior nares of the patient, and this patient is asked to blow gently on it. So presence or absence of fogging due to exhaled air on the depressor will give you the examination ki which nostril is patent or from which nostril air is coming out. Now with this instrument, what all you can do? So answer here will be all the above. So Renes can be done, yes. Weber's and modified Schwaber's test. So basically all the tests are the tuning fork test, and in Renes, you know, you the interpretation Weber's you also know. Many times you confuse with Weber's what is the interpretations. I'll tell you a simple mnemonic. Just remember a mnemonic called bus. So in Weber's, if hearing is lateralized to the better ear, it will be sensory neural hearing loss, and if it is lateralized to the worst ear, it will be conductive hearing loss. So CW and bus. So better ear, sensory neural hearing loss; worst ear, conductive hearing loss. Another thing is modified Schwaber's and airborne conduction. In both the tests, what we do is we test the hearing of the patient assuming the examiner's bone conduction as normal, and we place the tuning fork over the mastoid process of the patient and then on the examiner, and we compare the bone conduction hearing of the patient with the examiner assuming the hearing of the examiner is normal. So the interpretation can be normal as examiner or equal, same as examiner or reduced or lengthened. So what is different between airborne conduction and Swabash is that in airborne conduction we close the external auditory canal by pressing the triggers, while in Swabash we don't close it. So this is the only difference. You can just Google it also for getting a better understanding. The instrument shown here is Thiele's antral harpoon. So typical old type of instrument, not done nowadays, but previously a lot of antral punches were used to done with this. So this is just to create an artificial passage into the maxillary sinus through the nose via inferior meatus. Okay, but nowadays functional endoscopic sinus surgeries or via the endoscope we dilate the ostium in the middle meatus. This was the thing which was done previously by the ENT surgeons for antral puncture, also for removing the pus from the maxillary sinus. Now this instrument is very useful, called Walchelm's forceps. There is another forceps called Ash septal forceps. So you should see both are used for reduction of nasal bone fracture. So Walchelm forceps is used to work for reduction of nasal fracture bone, and Ash septal forceps is also, but it is quite different. The Ash is different. Ash is to be used over the septum, that is why it is also called Ash septal forceps, and Walchelm to be used over the nose. So if this is the septum, Ash will be used here and Walchelm will be over the lateral part of the nose. So this is the basic difference of use. Do see how the Ash forceps looks. So it has a typical features of like this, and then the ends are curved. So this is sort of Ash forceps. You can just Google it for a better picture. Okay, now this is a very simple, most commonly used instrument. Yes, you all know it is Thudicum nasal speculum. The use you all know for anterior rhinoscopy. It is used for seeing the anterior part of the nasal cavity. This is the Thiele's nasal dressing instrument of forceps, very common instrument. Now what test is being done here? So basically you are doing a cranial nerve examination, and if I ask you what test, it is corneal reflex. So for corneal reflex you should know some points, like the efferent for corneal reflex is nasociliary branch of trigeminal, that is V1, and efferent is facial nerve. So what happens is, on touching the cornea you evoke a brisk contraction of orbicularis oculi, and interpretation is, if both the eyes blink it is normal. If no blinking on either side, then there is a V1 nerve lesion, that is trigeminal nerve lesion, because both the sides are not blinking. And if there is no blink on one side, that is the side of the you are doing it, then there will be a facial nerve lesion. So this was the importance of this corneal reflex. Now the type of incision shown here is the end-oral incision. So this is called Lempert's end-oral incision. Okay, so here it is just another type of incision. The other type was Wilde's postoral incision, and this the shown here is end-oral incision, Lempert's end-oral incision. Again, they from the audiogram they want to ask, you can see a dip at 2K, already discussed the audiogram of otosclerosis. Now here they want to ask what type of nystagmus will this patient have. Now before that you should identify which canal they are showing. So you all know we have three semicircular canals, among which it is giving the arrow on the posterior canal. Yes, so here just remember that different semicircular canal stimulation will call different type of nystagmus. So nystagmus is horizontal for horizontal canal, nystagmus is rotatory for superior canal, and nystagmus is vertical for posterior canal. So this one is your posterior canal, this one is your lateral canal, and this one is your superior canal. So for superior canal it will be rotatory, for posterior canal it will be vertical, and for horizontal it will be horizontal nystagmus. So very important. Now they are asking what is the normal potential or the endocochlear potential in the endolimb. So the answer here is plus 80 millivolts. So direct current potential recorded on the scala media is plus 80 millivolt, generated from stria vascularis by sodium potassium ATPase pump. So very important probable question. This is just a figure of inclusion cyst of pinna. So slow growing benign lesion, usually asymptomatic, derived from plugged hair follicles or from inclusion squamous epithelial cell. Not very much important. Now here you can see a typical hearing loss at or more in the higher frequency, and if you see more particularly at 4000 here, 4000 hertz. So as the option has not mentioned, you will mark here sensory neural, but if it would have mentioned, then you can mark it as the noise induced hearing loss. So what is the figure showing? It is showing a pseudocyst of pinna, basically a painless swelling on the lateral or the anterior surface of the pinna. History of trauma may be there, and just a simple clinical picture. Now what is this test and for what it is being done? So very important for you, Dix-Hallpike and Epley's. So basically it is the Epley's maneuver which is being done for the positional vertigo, that is the BPPV. So this maneuver is used to treat, so it is the therapeutic maneuver, while Dix-Hallpike is a diagnostic maneuver for BPPV. So this Epley's is used to treat the benign paroxysmal vertigo of the posterior or the anterior canal. Principle is just repositioning the otoconial debris from posterior semicircular canal back into the utricle. So you should see how this Hallpike and Epley's are done, because they are very important. So the second part we'll be discussing in the course. I think this session would have helped you, and I wish your exam goes awesome and you achieve your targets, your dreams, and whatever you are aiming for. This is Dr. Shivam. Stay happy, stay motivated, and do whatever you want to do.